the high pressure that allows a high pressure that allows you to push fluid out, and this process is what we call the filtration. Second step of the urine formation, what happens if I did filter stuff that I need, like glucose? Would you like to get rid of the glucose if you didn't just eat it again?
No.
So I need to get, remember, filtration is allowed 100 to 120, 120 to 125 milliliters per minute. So you don't want to get rid of all this amount of water from your blood. So simply this will cause hypovolemic shock. So most of the water that you're going to be releasing out by filtration needs to be reabsorbed. So everything needs to be reabsorbed. You need to get it back here from filtrate back to your circulation, back to your blood. Remember, the part that is mostly concerned with reabsorption is going to be the proximal what we use to do. What if I told you that you need to spend energy, you need to consume energy in order for you to get all this back? Is this something like that makes sense? If I did already have all the stuff that I did just release, would you like to spend lots of energy to get all of them back, or you want to spend the minimum amount of energy to get everything back? Minimum amount. So if you are willing to save money, and you are on a trip for 2 days, and you want to take a shower, so would you like to get 3-in-1 shampoo, or to get 3 separate bottles, shampoo, body wash, and hand wash?
3-in-1.
3-in-1 or separate if you want to spend less money? 3-in-1, right? So this is what the kidney will be doing. The kidney will be getting 3-in-1, okay, 4-in-1. Alright, so I will be getting everything for free. I will just pay for sodium, and everything gonna be moving accordingly. So if I'm looking here, sodium is going to be reabsorbed back, and as I reabsorb the sodium, this won't be taking place unless I allow another organic molecule to travel with me. So you're going to be paying for the sodium to travel back from the filtrate to your blood, but you are allowing this sodium to travel only once you get an organic molecule with it. So let's say you did release amino acids out in here, in the filtrate. You are about to lose those amino acids. You are about to lose the glucose that you didn't release in the kidney tube. So you make it deal with the sodium. All right. So I will pay for you to get back to the blood, but you need to get with you one of the organic compounds that were filtered on you. So this type of transport is what we call a co-transport. So you're allowing 2 things to travel, paying only for one. So I will move here organic nutrients back by co-transport. So you did get glucose, you get amino acids, whatever. Back by co-transport with salt. Having lots of sodium in your blood, this creates a high osmotic suction pressure. Why? If you increase the amount of solids in your blood, what's going to happen to the water? What do you think? Water will follow the solid. So water here, did you pay for the water to travel back?
No.
Here at this part of the kidney? No. So water will follow for free. So how many did you pay for? Just one. You didn't pay for the sodium. Sodium did travel by co-transport with that organic nutrients. It did travel back to my blood, getting with it glucose, an amino acid. And as the sodium travels back to my blood, this creates a high concentration of solids back in my blood, and this will allow the water to travel from low solid concentration within my filtrate to high solid concentration within my blood. Did I pay anything for this water to go back to my blood? No. This is at osmosis. I didn't pay anything for the water to travel back to my blood. In this part of the kidney, network. What if you get lots of water back to your blood? What's going to happen to the concentration of the other substances? What do you think? So if I did have, let's say, this is my blood, this is my kidney tubule. I did allow the water to travel from my kidney tubule by osmosis. So let's say you did have let's say 5x per liter on this side, and here on the other side you have 5x per liter. Is there any net movement of the X substance? No. But if I did move water from this side to this side, so let's say here I have 5x now per half liter, and on the other side it's 5x in 1.5 liters. You did allow water to travel from the kidney tubules to your blood. So you did increase the amount of water, but not the amount of solids. This specific substance, X. Not sodium, any solute, any other solid other than sodium. Alright, so what's going to happen here? What is the concentration in my kidney tubules for substance X? So if I have 5x per half liter, this means I have how many x per liter? So if you have 5 in half liter, this means if you had 2 halves together, how many you have? 10. You have 5 per half, 5 for the other half, so you've got 10 per liter. Alright, so you've got 10 here, 10x per liter. How about this one? How many do I have per liter? 5 for 1.5. You know how to do this? 5, so 1.5. In other words, it's 3/2, right? So you multiply by the reverse, right? Right, so this means it's 3.3. Let's say 3. Alright, so you have 3x now per liter. Which side has more solid after you transport the water? 10x or 3x? 10x. So this means when you move the water, what's going to happen is the concentration of the different solids you are increasing the concentration of the solid in the filtrate compared to your blood. And any substance is trying all the time to move from high concentration to low concentration. So what's going to happen? Those cations that were located in your kidney tubules will start to pass back to your blood by diffusion. So why did I do the filtration in the first place if I would be getting everything back? Actually, you're not getting everything back. You will only allow what you need back, because those substances are not going to be passing by simple diffusion. They will be allowed to pass back to your blood by facilitated diffusion. You are the one who will create the channels and the carriers for them to be transported back. Did I consume energy for this to take place, for diffusion to take place? Yes or no? No. So you did pay how many times? One. And when you pay for the sodium to travel, it carries with it an organic nutrient. And as you get the sodium in, what follows the sodium? Water. So you get the water for free, you get the organic nutrient for free. And as you move water, what happens is the concentration of the other cations, it will decrease in your blood. And as it decreases in my blood, I will start to reabsorb them by diffusion. So after you allow water back to your blood, this will increase the concentration of cations, positively charged ions, and other substances, so they will start to pass back to your blood by diffusion. Do you pay anything here for the organic nutrient? No.
No.
For the osmosis to take place?
No.
No. For the diffusion?
No.
Alright, so sodium reabsorption is the one that provides the energy for the reabsorption of other substances. Again, how do I allow the organic nutrients to be reabsorbed? By co-transport with sodium. Will allow the co-transport, or what we call secondary active transport. So I pay for the sodium to get glucose with it. I pay for the sodium to get amino acids with it. This is secondary active transport, or what we call a co-transport. Co-transport. Here, water reabsorption is going to be taking place by osmosis. Why it will take place by osmosis? Because this water needs to follow the sodium. This is what we call an obligatory water reabsorption. It's not optional to reabsorb or not this amount of water in your kidney tubules. This is a mandatory water reabsorption. Alright? So again, where is the mandatory water reabsorption? It's going to be taking place in mainly in the proximal convoluted tubules. Mainly in the proximal convoluted tubules, again, under the effect of, due to the movement of sodium. It's mandatory. It's not optional. We're going to see the optional part later on. So please keep this in the back of your mind. So you're allowing this water to pass back here by allowing the sodium to pass first. So the water passes by osmosis following the sodium. Cations, and fat-soluble substances will start to move back to your blood by diffusion. you will get all this back by the heating. And it only pay for the sodium, which will provide the energy needed for the reabsorption of the other substance. So let's break down here the different parts of the nephron. What was the very first part of the kidney tubules? This was my proximal convoluted tubule. And the proximal convoluted tubule, this is where 65% of the sodium is going to be reabsorbed. Most of the water is going to be following here, the sodium, so 65 of the water that you did filter will be reabsorbed just in the proximal convoluted tubule. And remember, what favors the reabsorption in the proximal convoluted tubules is the presence of dense microvilli. Dense microvilli will be enhancing high rate of reabsorption in the proximal convoluted tubule. Ions, all the nutrients will be reabsorbed. Remember, if you have electric as you deposited in your account and so on. All the organic nutrients, all the expensive stuff will be reabsorbed in the very proximal part of the tubule, in my proximal convoluted tubule. In the loop of Henle, remember, the loop of Henle will allow you to form concentrated urine by allowing water to freely be reabsorbed. I am allowing free water reabsorption, especially in the descending limb. I am talking about one row of plant cells. In the ascending limb, I will be performing the reabsorption of some ions. At the same time, I will allow some secretion to take place, as in case of the urine. Distal convoluted tubules. This is the part which is going to be hormonally regulated in the nephron. What controls the reabsorption of sodium in this part of my kidney tubule is the aldosterone. And remember, where do you get the aldosterone from? What gland?
Adrenal?
Adrenal cortex, exactly. Adrenal cortex is where I will be releasing the aldosterone. And remember, what did we study last time that enhances the release of aldosterone from your adrenal cortex?
Renin?
Renin, how renin? Can you remind me how renin works? How renin increases your blood pressure?
Renin gets
Activated by angiotensin
Activates angiotensinogen.
Yeah.
Oh, like A2?
Angiotensin 1, and then angiotensin 1 will be increasing
Yeah.
your
I remember
blood pressure.
writing the diagram.
Can it directly increase your blood pressure? Angiotensin 1? No, it's still inactive. Still inactive. How
It
do you?
needs
ACE.
ACE, yes.
Angiotensin.
Angiotensin converting enzyme. It converts angiotensin 1 into angiotensin 2, and then angiotensin 2 increases your blood pressure by ways, which are constriction of my arterioles everywhere. Constriction of the arterioles will increase your resistance, increasing your blood pressure. And another way by enhancing sodium reabsorption. I did have a direct effect and an indirect effect. I have a direct effect on the kidney tubules, and I have an indirect effect by stimulating the adrenal cortex to release what hormone? Aldosterone. So in case of dropping your blood pressure, you're gonna be getting angiotensin 2, which will stimulate the release of aldosterone. And as you release aldosterone, now this part of the kidney tubules will start to reabsorb the sodium. It's hormonally controlled. It will not absorb the sodium unless you release aldosterone. All right? So will this be something optional or something mandatory reabsorption? What do you think? Is it mandatory?
No.
Or is it optional? Optional. So if you don't need it, would you release the aldosterone?
No.
So I will not release the aldosterone. I will not reabsorb. So it's optional water reabsorption. Alright? It follows the sodium, yes, but I might not be willing to reabsorb the sodium. If I have enough blood pressure, I will not be releasing the other schema. Another reabsorption will be taking place in here in my distal convoluted tubule is going to be the reabsorption of calcium, which is going to be regulated by PTH. If you remember what PTH stands for, this is my parathyroid hormone. And remember, PTH function is to increase your blood calcium level. You remember how do I increase the blood calcium level back from AP1? Do you remember AP1 first?
It was so long ago.
It was.
Yeah.
Alright. If you remember, you break bones. Yeah, you break down the bones. If you want to increase your blood calcium level, you break down the bones. Is there any sense if you did break down the bones and you get rid of the calcium that you did that resulted from the bone breakdown to be released out in the urine? Would you like to break down your bones and release the calcium in the urine?
No.
No. So there is no meaning for me to break down my bones if I would be releasing this calcium out. So if you are releasing PTH, this means you have a drop in your blood calcium. And if you have a drop in your blood calcium, I would start to break down my bones to release the calcium from the bone to the blood. And as I raises the blood calcium level, I want to reuptake any calcium that might pass out in the urine. If I have PTH, this means I have a problem with my blood calcium. And if I have PTH, I need to get any calcium that might pass out in the urine. All right? But somebody will say, yeah, if a person got hyperparathyroidism, he will get kidney stones. How do you explain this? What do you think? So if I have hyperparathyroidism, I have lots of PTH, I should be reabsorbing all the calcium, right?
It's a lack of.
So how would the person
Lack of
with
vitamin D.
hyperparathyroid hormone will get a kidney calcium kidney stones? You have too much calcium that will exceed the ability of the kidney tubule to be reabsorbed. The same concept like having diabetes. If I have diabetes, I have lots of sugar that will be filtered down here. And why would I be releasing glucose out if I have the reabsorption of the organic nutrients on here?
That's too much glucose.
Too much glucose that will exceed the ability of those cells to be reabsorbed. So yes, I will be breaking down lots of bone in case of hyperparathyroidism, but at the same time, I will be performing my maximum reabsorption. I cannot reabsorb anymore. That's why lots of calcium will still remain in the filtrate and will be released out in the urine, forming the kidney stones.
So,
All right.
so with that, over time, wear the kidneys down if you're having too much calcium like that. Like diabetes will do that. It will like wear the kidneys down.
Yeah, so you might have kidney complications, but you need to make sure to remove the glands because this most likely is an active adenoma, like an active tumor releasing the hormone.
Okay.
Alright, yes, there will be complications because of the stones, but also you need to take care of why do I have hyperparathyroidism. Alright? Moving on to the last part here that's going to be collecting the urine from the different backgrounds, and we'll conduct this urine down to my renal pyramid, to the outside, to the minor calyces, major calyces. So this would be my collecting duct. And collecting duct is gonna be allowing water reabsorption, but this would be taking place under the effect of ADH. Can you remind me what's ADH stands for? Antidiuretic hormone. So you see on here, the water reabsorption that takes place in my collecting ducts, this is under the effect of ADH. So ADH here will insert channels within my collecting duct cells, and those channels will allow the water to be reabsorbed back into my circulation. So is this an optional water reabsorption or is it a mandatory water reabsorption? What do you think? Is it something that I have the option to reabsorb or not, or I have to reabsorb it?
You
I
have to.
have to reabsorb it, right?
Yeah.
Yes?
Yes.
Can
Yes.
you remind me of the third way by which angiotensin II is increasing your blood pressure? Acts on the hypothalamus to release ADH. So would you like to release ADH all the time? No. So you like to release ADH or not according to the state of your blood volume and blood pressure, right? So is it optional now or mandatory reabsorption? Optional reabsorption. So it's according to your needs. According to whether I have enough blood volume, you don't need to release ADH. I don't need to release ADH because simply I will not have angiotensin II. And why didn't I have angiotensin II? Because I didn't release renin. And why didn't I release renin? Because simply I didn't have any reduction in the degree of stretch of the granular cells in the juxtaglomerular apparatus. Right? You remember something like this? 48 hours ago? Alright, so also here, aldosterone will also act on the collecting ducts by enhancing the sodium-potassium antiport, so you perform an exchange. Take sodium, release potassium. Also, in the collecting ducts, you're going to be regulating your blood pH by either reabsorbing or secreting hydrogen and bicarbonate. So if I have lots of acids, would you like to get rid of the hydrogen or to keep it? If I have lots of acids in my blood, I'm about to have acidosis. Would you like to keep hydrogen or release the hydrogen out of the urine? Release it out of the urine. And if I have alkalosis, would you like me to release lots of acids in the urine or to keep them? Would you like me to release hydrogen or to keep it? If I have alkalosis, lots of alkalis, in order to neutralize the alkalis, I need to keep my acids. Because if I don't have acids to equalize the alkalinity of the alkalis, I will develop alkalosis. So where is this going to be taking place? Again, in my collecting ducts. Collecting ducts will allow you to regulate your blood pH. So the blank cells of the juxtaglomerular apparatus secrete blank when blood pressure is low. What do you think? B, B. Any other ideas? B. So B.
Bailey said E.
E.
E. Alright, go back to your notes. Go back to your notes.
What was it?
So you release renin, yes. We don't all agree that it releases renin, yes. To increase the blood pressure. We just mentioned that angiotensinogen will be
Triggered when the creator
activated under the effect of renin. So you're gonna need to release renin from the juxta glomerular apparatus. But who will release renin?
the granular cell.
Which is located in the form of granules in the cell. Cells that are called granular cells because they have granules called the macula densa, which are modified cells of the loop of Henle. What do you think?
Oh,
So I keep renin in the form of granules in the cells. So they are located in what cells? Granular cells. Granular cells will be releasing renin. And can you remind me, granular cells are acting as what kind of receptors? What kind of receptors? Mechanoreceptors. Those are modified smooth muscles of my afferent arteriole. Go back to this slide here. One of the most important slides in those two chapters. Remember, granular cells are modified smooth muscles of the afferent arteriole. They will be releasing renin and they are acting as mechanoreceptors. Macula densa, those are modified cells of the ascending limb of the loop of Henle, and they are acting as chemoreceptors detecting sodium concentration. So again, who will release renin in case of drop of the blood pressure is going to be my granular cells. Granular cells. So the answer is
B.
B. So what if I have stuff that I want to get rid of after I did perform the filtration? I was not able to get rid of them, and I still have them in my circulation. What do you think you will need to do? What do you think you will need to do?
Reabsorb.
You need to keep it?
You need to reabsorb.
You need to secrete it outside. Release it to the outside by tubular secretion. Reabsorption and secretion are taking place at the same time. So, why didn't you filter everything? But if I want to release it, if I will secrete it later on, this is the first question. If I will secrete it later on, why didn't you filter it? Or if you're gonna need to secrete stuff after the filtration, why did you have filtration in the first place? Why you didn't just simply secrete everything? So we have two questions here. Why I have secretion, although you did filter, because there will be stuff that you don't need. But how those stuff you don't need, are still kept even after filtration? The one question. And if you're gonna be secreting, why you didn't have filtration? So if I would be secreting, why didn't? All right. So forget about all this. Why would I filter? Why would I filter and then reabsorb and then secrete? So why would I do all this if I would be secreting later on? Why I don't just simply one step of the neuroformation is secretion and that's it?
Are they connected to other important things that have to be broken down and followed?
Would it be too much work?
So if I have secretion, why did I do filtration and then reabsorption? And we did filter lots of 175 liters per day, and then we're gonna be getting back 99% of them. Why did I do all this?
Body has to function, so what if you release everything, you secrete it, then probably your organs will not function.
If you secrete it all, you won't be able to do
So,
anything.
if I will secrete, why you don't secrete everything?
You have to have
Why
something
did you
reserved.
filter, reabsorb, and then or
Maybe. Yeah.
secrete?
Because that's not instant, is it?
Secretion and reabsorption are taking place simultaneously, well at the same time.
The whole like filtration, like from the kidney all the way to the end, that's not instant, right? Because your body would change. would need constantly, so you'd have to absorb and release depending on what, if you're,
This is a very good one. So you might not at some points need to keep the hydrogen, and in some others you need to release the hydrogen, so you want to regulate. It's not all or none. You don't need to get all of the hydrogen out or to keep all of the hydrogen.
Controls blood flow.
Yes, this is why I would have why would I have secretion?
This sounds,
Why you didn't release
sounds like a
everything from the
nervous
first
system issue.
place? Yes, simply because you, in some cases, will need to regulate, not just get rid of stuff. So like the hydrogen, like the bicarbonate, you need to regulate the amounts that you keep, not only getting rid of them. So that's why I would have secretion. But why didn't I rely only on secretion?
Because it's gonna continually change.
Why don't just have secretion? Why did I filter, reabsorb, and then secrete? Even if it's changing, I will be regulating this secretion. Like if I have lots of acids, you're gonna be secreting only the hydrogen, like what you do in here. You increase the secretion of the hydrogen only. You increase the secretion of the bicarbonate. What do you think? Why don't just simply have only secretion? So we didn't answer why would you
No filter?
have secretion even with the filtration? Yes, because simply in some cases I will need to regulate, not only get rid of all the stuff.
So just secrete, no filter?
Yeah, why I don't have this secretion without filtration?
Because there are other substances that you have to get rid of that are not being used, so some things that need to be filtered
But
out.
yes, yeah. So why did you filter it, reabsorb all the stuff that you need back, and then you still have stuff that you didn't get rid of? You're gonna secrete it later on. Why you didn't just cancel all what we've done here and you just secrete?
Because from what that's saying,
So something like the urea, for example, you need to get rid of all of it. Some of the urea will be released by filtration, and the remaining part of it is going to be released by secretion. Why you didn't just rely on the secretion? You didn't throw it away. You reabsorb 99 and you secrete 1%, but why didn't I just secrete everything? Why did I filter and then reabsorb 99? Why didn't just release this 1% out and that's it?
because what the slide is saying is that some are bound to the plasma.
So this is something that you're gonna need to get rid of. But why I didn't do it just by itself, the secretion?
Because some are bound
There's
to
something
the-
wrong with the
So
filtration
something is
process.
bound, will not be filtered, and it needs secretion. Yes. But why I didn't have just secretion? Simply because I will not be for free. I will be consuming energy to secrete those substances. If you decided to get rid of every substance by secretion, this will be a great loss of energy. You cannot do this. Here, how did I move the filtrate? Here. How did I move the fluid from my blood vessel in the glomerulus to my bolus capsule? By the hydrostatic pressure that I create by the contraction of my heart. It's going to be much cheaper to contract your heart to push the blood to your glomerulus rather than to actively secrete everything from scratch. So I need this secretion like to give like the final tuning of my urine concentration. You modifies the final shape of the urine according to my needs. but I cannot just simply rely on it because it's gonna be consuming lots of energy. It's gonna be much cheaper for you to filter everything and then reabsorb what you need back, and then secrete what you don't need. It's gonna be much cheaper than to secrete everything from scratch.
Makes sense.
All right? Are you convinced? All right.
I'll go with
So,
it. I'll go with
like
it.
what you said here. What will I need to secrete? Like something I need to regulate, not only to get rid of it. Whatever you have a substance that's going to be attached to a plasma protein, would you be able to filter it? What do you think? No. Why? Because plasma proteins are negatively charged. Remember? And your filtration membrane did have a layer which is also negatively charged. What was the part of the plasma membrane? Is the filtration membrane that was negatively charged? This was my basement membrane. Basement membrane is negatively charged, so I will have a repulsion between the plasma proteins and the basement membrane, and any substance that's going to be attached, bound to my plasma proteins, will not be filtered. So would you like to keep this medication forever in your system? No. You need to actively now throw it out into urine by tubular secretion. So in case of calcium, in case of potassium, in case of hydrogen, bicarbonate, all this need to be monitored. We cannot just simply allow them back in by reabsorption. You need to actively regulate what should pass back to your blood and what should be kept out in the urine. All right? What else? What else do you need to release out by tubular secretion? If something like the urea creatine that you need to get rid of did pass back during the reabsorption. During reabsorption, what was the final step in here? It's diffusion. And why did I have this diffusion? Because when you move the water by osmosis, you did reduce the concentration, and one of the substances that's going to be reducing its concentration is going to be the urea, for example. So the urea will start to travel back from your kidney tubules to your peritubular vessels. And as you get this urea back, would you like to keep it?
No.
You want to be actively releasing this urea that has been reabsorbed by active secretion. Again, why you didn't just rely on the secretion to get rid of the urea is going to be so expensive. I will consume lots of energy to get rid of all the urea by secretion. It's going to be much easier and much more cost effective if I did remove most of it by filtration, and then if I got some few of it back, I will actively secrete it out of the urine, rather than relying on active secretion all the time. All right?
So even if it passes your blood back to your blood, it will secrete it?
Yes. You don't want to keep it. You don't want to keep any amount of the undesirable substances like the urea and uric acid. So even if some of it did pass back to your blood by diffusion because of the water
Osmotic.
that moved before it by osmosis, you're gonna be in need to get rid of it. All right?
Okay, so how does that happen?
Formation of dilute urine. If I did drink lots of water, what's gonna happen? I will release ADH, or will I prevent the release of ADH? What do you think? I drink lots of water, do you want to release ADH or stop the release of ADH? This kind of questions gets you confused on the test. Alright, so break it down. What was ADH? Anti-diuretic hormone. So it prevents water loss in urine. If you are drinking lots of water, would you like to retain the water or release the extra water out in the urine?
Release the extra water.
Release the extra water out of the urine. Out in the urine. So would you like to release ADH or to stop the release of ADH?
Stop the release.
Stop the release of ADH, because ADH function is to retain the water, and you don't want to retain the water. So when you drink lots of water, what's going to happen to the ADH?
Decreases.
So in the absence of ADH, what's going to happen? You will not reabsorb the water in your collecting ducts. And if you did not reabsorb the water back in the collecting ducts, what's going to happen? What's going to happen? Water will remain out in the urine, and this will cause what is the color of the urine? What do you think?
Clear.
It's gonna be clear. It's gonna be clear. Because this amount of water that you were about to retain because of the presence of ADH, you did actually release it out. And if I release it out, what's going to happen to the color of the urine? It's going to become clear, it's going to be pale in color. This is what we call dilute urine. What if I am not getting enough water? What's going to happen to the color of the urine first? It's going to become dark. And why will it become dark? Would you like to release ADH or do you want to prevent the release of ADH if you're not drinking water?
I want to release ADH.
If I'm not drinking enough water, would you like me to release or stop the release of ADH? Release ADH, prevent ADH.
Release ADH.
You release ADH to retain water? Yeah. Would you like to retain water if you're not drinking?
You want to retain that water.
Yes. So if I'm not getting enough water from outside, I will release ADH, and as I release ADH, those aquaporine channels in the collecting ducts are going to be inserted, and you're going to get back the water from the filtrate in the collecting ducts. So what's going to happen to the concentration of solids? If you are reabsorbing more water, what's going to happen?
Dilute.
It's going to be concentrated or dilute urine.
Dilute.
Concentrate.
Dilute it.
Wait,
Because
what
the
was
water,
that?
the water dilutes it.
Reabsorbing the water back from the filtrate. I get the water out of the urine. So what's going to happen to the
Oh, it will be
amount of
concentrated.
fluids in the urine? That will become
Concentrated.
at a higher concentration. So this is what we call again concentrated urine. So again, yeah, a lot of twists on here. So again, if you're drinking lots of water, what's going to happen to the ADH level?
It decrease.
Decrease.
Decreases.
And when you decrease ADH, what's going to happen to the water retention?
It's gonna decrease.
So go back, ADH is retaining water.
The water.
And when you stop the release of ADH, will you retain water?
No.
So you will not retain water. So what's going to happen to the urine? Will it become concentrated or dilute?
Dilute.
Dilute urine. If I'm not drinking enough water, what's going to happen?
The
The ADH level that you release,
will increase.
it's gonna increase. And when you increase ADH, what's gonna happen to the retention of water in your blood? Increases. You're retaining more water.
I keep getting confused.
And as you retain more water back in your blood, what's gonna happen to the amount, the concentration of solids
It's
in the
gonna
It's
urine?
gonna concentrate.
Increases the concentration because you're pulling out water, so the concentration of the solids will increase. So what's gonna happen to the urine? Will it become dilute or concentrated urine? It's gonna become concentrated. Alright? Because of the water reabsorption will take place, this is the optional part. The facultative is the optional water reabsorption, and once it takes place, you're going to be reabsorbing 99% of the water that you did allow to pass out by filtration. Can you remind me, what is the amount of water that you're going to be reabsorbing just in the proximal convoluted tubules?
65.
65% is going to be reabsorbed just in the proximal convoluted tubules. Where is the facultative water reabsorption going to be taking place? In which parts of my nephron?
The distance.
Distal convoluted tubule and my
Collecting duct.
collecting ducts. In the distal convoluted tubules, who will be acting on the distal convoluted tubule cells to enhance sodium reabsorption, which is going to be followed by water? What hormone? What hormone?
No, not really.
It's
Aldosterone.
aldosterone, yeah, that's the one.
And who will be acting on my collecting ducts? This will be mine. ADH. Is the water that you reabsorb in the distal convoluted and the collecting ducts, is this a mandatory reabsorption or is it a facultative water reabsorption?
Optional.
Optional. It's not mandatory to get this amount of water. You're gonna modify it according to your needs.
Right.
So, short story, diuretics. So you went to the bar with one of your friends, and you did drink lots of alcohol.
Okay.
So he's not able to drive. So what you're gonna do for him? You're gonna give him coffee to drink, for example.
Huh?
Right. You're gonna give him something sugary to enhance his mental abilities, right? Brain needs more sugar. You're gonna give him some sugar, like a donut, for example, and coffee for him to like regain his consciousness.
No.
Alright, what's gonna happen to him after that?
He gonna crash. He gonna crash like a motherfucker.
Or the car accident. You will stop first in the first gas station on your way back, because you did take all the 3 kinds of diuretics. And what's diuretic? Diuretic is water released in you, right? So those diuretics, like what? Like osmotic diuretics, like glucose. If a person has diabetes, what's going to happen? You are releasing lots of glucose in here, in the proximal convoluted tubules. Would you like to get this glucose back? Yes or no? Yes. You're going to be reabsorbing by co-transport with sodium. So most of this glucose is going to be reabsorbed. Yes? Normally. All of this glucose is supposed to be reabsorbed. But if I have diabetes, lots of glucose will not be reabsorbed, because all the carriers responsible for you to reabsorb this glucose is going to be, they will be saturated. You're going to have saturation of the receptors responsible for you to reabsorb this glucose back. So what's going to happen? You're going to have glucose that you failed to reabsorb. So what happens to the amount of solutes in your filtrate? If you are not able to get this glucose back, what's going to happen to the amount of solutes out in the filtrate? It increases, because you still have glucose, right? So can you remind me of these 3 effective pressures that did affect my filtration? So we've seen a hydrostatic pressure from the glomerulus, right? We've seen hydrostatic pressure from the bolus capsule, and we've seen an osmotic pressure within my glomerulus, right?
Glomerulus.
So we had a blood vessel, this is the glomerulus,
What did he say that was?
and this is the bolus capsule. I'm here. I'm looking at the filtration now. If you remember, we have tissue perfusion, and this creates hydrostatic pressure that's going to be enhancing filtration to take place. So you're pushing water out of your vessels due to the pressure created by your tissue perfusion. And remember, the pressure here will equal to 55 millimeters.
millimeter mercury.
It's going to be opposed by the presence of fluid on the other side. Remember, if you have water, it creates pressure, hydrostatic. So the opposing pressure created by the filtrate is equal to, can you remind me?
30.
50. It pushes back by a force of 50. Right? If you remember, did I allow everything to pass from the blood to the filtrate, or I kept plasma proteins, I kept my red blood cells, blood cells in general, I kept a lot of stuff. I didn't allow everything. I kept macromolecules, I kept my blood cells, I kept my plasma proteins. So you've got a lot of stuff in here in your blood that did not pass your filtrate, right? And if you remember, at that time we mentioned that this will have a much higher solid concentration compared to my filtrate, right?
Yeah.
And having higher solid concentration on one side, what's going to happen? Water is going to be moving from low solid concentration to high solid concentration. It's going to be pulled back your blood. So this will create a force, an osmotic force, and we call this the glomerular colloid osmotic pressure. And remember, this is equal to 30 millimeter mercury. And remember, will I be allowing any filtration to take place at this point?
Yes.
Yes, if I'm pushing from one side by 55 and I'm opposing this force by 45, you're gonna get a net filtration pressure of 10 millimeters mercury. Do you remember this? Am I missing something here? I did consider osmotic pressure only of the blood, right? If you remember last time, in the time before, when we mentioned this, we did only consider the osmotic pressure of the glomerulus. So I did not mention that we have any solids. Do you have any solids in here? In your filtrate, do you have any solids? Yeah. But normally it's negligible. I will not consider it. It is so small compared to the osmotic pressure of my glomerulus. But if, in this case, I have diabetes, what's going to happen? Now it's not negligible. If I have lots of glucose in the filtrate, what's going to happen? You are creating a significant osmotic pressure in your bolus capsule and in your kidney tubules. So what's going to happen at this point? If I have lots of glucose because I have diabetes, what's going to happen? It's going to be putting water. So water is going to be moving from my blood to my filtrate. And as I add more water to the urine, this is what we call diuresis. So why patients with diabetes will have excess thirst sensation, excess micturition. Why? I'm losing lots of water out in the urine, so I need it to be replaced. So I will have patients with diabetes will be manifested by polyuria, polydipsia. I go to the restroom more frequently and I'm drinking much more water. This is what we call an osmotic diuretic. So yes, alcohol also gonna be a diuretic. Alcohol, but this time, what is the main organ that the alcohol gonna be affecting instantly is your brain. And what is the part of the brain that we are concerned with in here is gonna be the hypothalamus, because it releases ADH. So one part of the brain that's gonna also be inhibited by the effect of alcohol, this will be hypothalamus, that's gonna be releasing ADH. So I will inhibit the release of ADH here by alcohol. And if you're not releasing ADH, what's gonna happen to the water retention? Would you retain water?
No,
Would I reabsorb this water?
no.
No. So if you did not reabsorb it, what's gonna happen?
You're gonna lose
It
water.
will be released out in the urine. So I will be dehydrated. So another type of diuretics is gonna be
They still don't have like filters. You have to know how to set it up. That they can say.
Alright, so moving on. Here's the questions and really on the reabsorption will take place in which part?
C.
Going to get substance deposited, you get it as soon as possible here, proximal contribution. Proximal contribution. What's renal clearance and why do I need to calculate renal clearance? Renal clearance is the volume of plasma that has been cleared from a particular substance. So I will be injecting a substance, like inulin. And the inulin is going to be released out in the urine. When we calculate the renal clearance, we are measuring the amount of plasma that we have been able to clear out from this substance. Which is it? Why inulin? Why inulin? Because inulin doesn't get into chemical reactions of yourself. You will not be performing any reabsorption. You're going to be releasing it out mainly by filtration. No reabsorption for it will be taking place. So this gives you an impression about how good your kidney is going to be performing filtration. So I'm expecting here that the renal clearance of the inulin is going to be a marker for my GFR, my glomerular filtration rate. So why do you think I will need to calculate the renal clearance? Why would you inject a person with inulin and then calculate his renal clearance to check his GFR? Why would I care? What is the GFR? Glomerular filtration rate. What do you think? Check how good the kidney functions? Yes?
Yeah, that sounds about right.
Yeah? Why you don't just simply measure the urea in the blood, urea, nitrogen, and kidney function test measures the amount? Why would you inject and start to collect the inulin and to measure the GFR at the end?
Because all the data isn't there in the urine.
So part of the urea is going to be reabsorbed, so this doesn't give me like a very sharp picture about the filtration, yes?
Yes.
Exactly. Also, something I need to check is whether or not I have just glomerular damage. And if I was able to identify that there is a glomerular damage, you are interfering with the filtration only. You might be secreting some of the urea in here. Urea will be secreted. You are willing to measure only filtration to get a state about the glomerulus and the filtration membrane. I want to measure just the GFR. Once you detect that there is a problem, what you're gonna do for this patient, you give him treatment, right? So for example, if I have an autoimmune disease that will be attacking the filtration membrane, we're gonna be giving the patient corticosteroids, something to lower down his immune responses. Because this is an autoimmune disease, he is attacking his own kidneys. Alright, so I want to check later on whether the treatment is effective or not, or should I increase the dose, should I decrease the dose, what's going on? How would I know? How would I check the progress of the disease? How would I check the effectiveness of the treatment? By checking renal clearance. So I didn't have this renal clearance, now I have much worse renal clearance. So this means my treatment is not working. I need to try to find another way to treat this patient. So it allows you to follow up the disease. It allows you to check in the first place the presence of certain specific diseases that are only interfering with the filtration. Moving on to the ureters. Remember, the ureters are going to be muscular tubes that will be conducting the urine in the form of droplets from the renal pelvis coming out of the kidney down for this urine to be collected down in the urinary bladder. Remember, ureters, kidneys are retroperitoneal. Retroperitoneal means behind the peritoneal cavity, so away from the other abdominal wall. The ureters are going to be connected to the urinary bladder from the posterior wall of the urinary bladder. So you see on here, the ureter will join the bladder from its posterior wall. The ureters will conduct the urine from the posterior wall of the ureter. Why doesn't it simply go down directly to the bladder? So why it's not like what I did draw last time? Something like this. We conduct the ureter down from the kidney to move it up on the superior surface. Why the posterior surface? Why would I need to rotate and get to conduct the urine from the dorsal surface of the urinary bladder, not just the superior surface? Why don't go directly and allow the urine to travel directly down to the urinary bladder?
So you're asking why it comes from the back and not the top?
Yes.
Oh, I thought you said that earlier.
Why doesn't the ureter get connected to the superior surface? Why would it be connected to the urinary bladder from the posterior surface?
Is it because the ureter is connected to the kidneys and the kidneys are in the dorsal aspect?
Even. You have all the space inside, you can move around.
Occupado.
By other organs.
Is it logical? Is it logical to reconnect to the posterior aspect, not the superior aspect? Although you do have all this space to move around. Why would you need something like this to happen? Why would I need something like this? Do you want the urine to to move up back to the kidney at any point?
No.
So when can the urine pass up back to the kidney? Whenever you contract the urinary bladder, right? So when I contract the urinary bladder, what makes the urine travel from the urinary bladder to the urethra, to the outside?
Pressure.
Creating a high pressure within the urinary bladder. Remember, like what we've learned with the heart, whenever you reduce the volume, what happens to the pressure inside? Increase. So if I'm contracting the urinary bladder on here, squeezing the urinary bladder, I'm increasing the pressure here, right? If I was connecting the ureter directly to the superior surface, what's going to happen? The urine will flow up and down from high pressure to low pressure. So it's going to go, part of it will go back to the kidney and part of it will move out in the urethra. But this doesn't happen. Why? Because simply when you join the urinary bladder, the ureter, when the urinary bladder contracts, it's going to kink the ureter. It will act as if it was a valve. So it's open all the time. It will block the connection here between the ureter and the urinary bladder once the urinary bladder contracts. And once it contracts, it kinks the ureter. So it's acting as a valve. It prevents the backflow of the urine up back to your kidney. Alright? So again, why would it be connected to the posterior surface of the kidney? Because the urinary bladder pressure will increase during micturition, and you don't want the urine to go back up in your kidneys through the ureter, so you need to close the distal ends of the ureters. And would I be able to close them if they did join the urinary bladder from above?
No.
So you are able to close them when you contract the urinary bladder because simply the ureters are joining the urinary bladder from the posterior surface. Alright, questions? Urinary bladder, how is it located in the pelvis? You see on here. In the female pelvis is going to be located just in front of the uterus and the vagina, which also going to be located in front of the rectum. For males, it's going to be located in front of the rectum, behind the symphysis pubis or the pubic symphysis of the pelvis. That's why fracture in the pelvis puts a person at risk of having urinary bladder rupture. If a person got into a car accident and he had pelvic fracture, the pelvis fracture might cause rupture of the bladder or injury to the bladder because the bladder is directly behind the symphysis pubis and pubic symphysis. Alright, so first organ I will get in contact with if I've got a pelvic fracture is going to be the bladder directly behind the anterior wall of my pelvis. In males, the neck of the bladder that's going to be connecting the urine down to the urethra, and part of the urethra is going to be surrounded by a gland. This is called the prostate gland. Prostate gland. We're going to discuss the prostate gland in details in the next unit. All right. So if a person has frequency, he has difficulty during micturition, we need to check benign prostatic hyperplasia. So how would I know whether I have an enlargement of the prostate? Just so simple by rectal exam. So you check it out, you pass fingers inside the rectum, you press. What is the first thing that you're going to get in contact with from the rectum is going to be your prostate gland. Prostate. So this gives an idea whether a person has cancer, whether he has just a benign prostatic hyperplasia. Those are two different. Benign prostatic doesn't turn into cancer. Cancer is going to be firm, is going to be much more solid in consistency compared to the benign prostatic. Is going to be more soft.
Are those pink things intestine?
Those pink things.
The two black things.
This one.
Oh, I was looking to see.
This is the rectum. The lowest part, the lower part of the food. Right? Rectum, this is the anus.
Right.
This is the anus. Above it is the rectum.
Yes.
Right? So this is the very distal part of my colon, of the large intestine.
I'm trying to see where.
Yeah, so but we then remove every other part of the intestine just to make it we are checking on here the relationship between the pelvic. Question? Somebody did have his raise his hand? Alright, so urinary bladder is also retroperitoneal, outside of the peritoneal cavity. In males, the prostate gland is going to be surrounding the neck inferiorly. In females, it's going to be located anterior to the vagina and uterus. You see on here the muscles of the urinary bladder. This is called the detrusor muscle. The ureters are releasing the urine, joining the urinary bladder from the posterior surface. Those holes, those openings of the ureters that will be conducting the urine to the urinary bladder, those are called ureteric orifices. Those ridges that we can see on the mucosal lining of the urinary bladder from inside, those are called rugae. And you see on here, the peritoneum is covering the outer part of the urinary bladder because the bladder is also outside of the peritoneal cavity. Yeah, we're not inside of the peritoneal cavity. We are retroperitoneal. If I keep moving down, the urine is going to be passing through this funnel-shaped part of the urinary bladder. This is called my trigone, and the trigone will be conducting the urine down into this vascular tube. This is my urethra, and the urethra will have two sphincters. Two sphincters in the urethra. We have the internal and the external. We have internal urethral sphincter and external urethral sphincter. So if we're looking here at the urethra, in males, I have three parts of the urethra. In females, I have very short urethra compared to the males. So in males, the urethra is going to be divided into three different parts. We have the part that passes through the prostate gland. This is called the prostatic urethra. Then the part that passes between the prostate gland and the penis, this would be the membranous or intermediate urethra. And then the urethra that travels inside the penis, this would be the penile or spongy urethra. This is going to conduct the urine to the outside through the external urethral orifice. Females will have much shorter urethra, which will put them at a higher risk of getting UTIs, urinary tract infections. All right, so the bacteria will be able to walk up a short distance for it to reach the mucosal lining of the urinary tract. So it's going to be much easier for it to cause an infection of the tract in females compared to males. Again, why? Because of the length of the urethra in females is about 4 centimeters compared to in males, it's going to be around 20 centimeters. All right, so this would be almost 5 times the length of the urethra of females. And again, what are the three portions of the male urethra? Part that passes in the prostate, guess what? Prostatic urethra. The part that passes in between prostate and the penis, this would be intermediate urethra or membranous urethra. The part that passes into the penis, this would be penile or spongy urethra. Penile or spongy urethra. Two sphincters of the urethra. We have the internal is under involuntary control. Compared to the external is going to be under voluntary control.
Okay.
So again, two sphincters of the urethra. We have the internal urethral sphincter. This is under involuntary. Remember, internal is always involuntary, and external is going to be under voluntary control. So what's going to happen is micturition. Is it voluntary or involuntary? What do you think?
Involuntary.
Voluntary. So whenever you decide to micturate, you can.
To what? What?
So
Yes.
if you decide at any time to micturate, to avoid the urine micturation, pee.
Oh, okay.
This is a scientific word for pee.
Say Pete.
Yeah, just say P.
Oh.
Micturation.
Yeah, I'm like, huh?
Or urination.
So, is it under voluntary or involuntary control? What do you think?
I think
It's voluntary.
Like, it's to an extent.
So micturation itself, the urinary bladder contraction and the relaxation of the internal sphincter, this is under involuntary control. This is under the regulation of the parasympathetic nervous system. But what you do have control of is just the external urethral
Oh,
sphincter.
you're right.
You were partially right.
Alright, so whenever I fill the urinary bladder with urine, what's going to happen? Urinary bladder will be distended, and the stretch receptors in the urinary bladder will send signals to my spinal cord. The spinal cord will respond by sending out motor impulses, and the urinary bladder will start to contract. In the same time, the internal urethral sphincter will dilate. Alright, so urinary bladder will contract, internal urethral sphincter will dilate, and at this point I will feel the urge to make it. Hold it.
Right.
How do you hold it?
With your external.
With your external. Alright, so internal will dilate by contraction. How do you dilate something by contraction? See on here? This is how the internal sphincter will look like. So whenever you stretch the urinary bladder, because it's filled with urine, parasympathetic will send signals to the urinary bladder for it to contract, and for the internal sphincter also to contract. You see on here? But I will contract, and as I contract the internal sphincter, it's going to be dilated. So here, the internal sphincter dilates by contraction. And this is so logical. If I'm sending the same signal, how come one muscle will relax and the other muscle will contract? How come the urinary bladder itself will contract and the sphincter will relax? Actually, both are contracting in response to the same signal. But how the fibers are arranged in the sphincter, this is what allows it to dilate. So the dilation of the internal sphincter is due to the muscle contraction. You don't have to constrict when you contract. You can dilate when you contract. So the very first step, urinary bladder contracts, internal urethral sphincter will contract, and once it contracts, it dilates. But how would you contract your external? External is under voluntary control. It's gonna be formed by what kind of muscles do you think? If it's under voluntary control, which type of muscles do you control? Your skeletal muscles. Skeletal muscles of the external. Now, this is how they are arranged. So the fibers, once they contract, they will close external urethral sphincter. So would you be able to focus in class if you are holding, contracting external? Why? Part of your brain is so concerned with the external urethral sphincter. All right? But in order to complete the micturition, just 1 second, what you need just is to relax. Right? So what would you relax is external urethral.
So what happens when people can't move? Like what?
It might be due to hyperactivity of the urinary bladder. It might be due to weakness of the external urethral sphincter. So the pressure in the urinary bladder exceeds the pressure created by the external urethral sphincter. Alright, so I might have like an overflow, for example. This is something that we're gonna be talking about in continence. An overflow in continence. So can you hold it forever?
No.
Yes?
No.
Alright, so why you cannot hold it forever? Because
Physics
first
won't
is
allow it.
this is skeletal muscle. It's fatigable. Remember, skeletal muscles are fatigable compared to the smooth muscles.
Right.
So at some point, your external sphincter will
Blow up.
Give up.
will be fatigued. And it won't be able to keep contracting. So the pressure in the urinary bladder will be higher than the external urethral sphincter. So you can have urine moving out.
Oh.
This is an overflow incontinence. So if I have hyperactive urinary bladder, this might cause incontinence. If I have weakness in the external sphincter, this might cause incontinence. Alright?
So for like women who've had multiple children, why does that mean, like, I know that would mean that they have more incontinence. Why is that?
Because every time a baby will pass, I'm pulling on the muscles that will form the pelvic floor. And one of those muscles is going to be the levator ani, which is going to be forming the floor of the pelvis that will help you contract it. And what it contracts for you to hold here the feces and the urine from passing outside to the outside. Alright? So because of the stretch, you see, if you go back on here, so you see we have muscles on here in the floor of the pelvis that are surrounding urethra, vagina, and the rectum. Alright? So multiple stretches here will be weakening the floor of the pelvis. Alright? Especially if it's a prolonged labor, for example, so the head got stuck in the birth outlet or something. Alright? So, chemical composition of the urine. 95% is going to be water, and 5% is going to be the solids that you're going to be getting rid of. 5% is a huge concentration. Don't think that this is like extremely stuff. It's too much compared to any other fluid that you can. Nitrogenous wastes will be representing a big part of those 5%, like the urea, uric acid, creatinine. Also, normal soils that you want to regulate the concentrations in your blood, like the sodium, the potassium, the phosphorus, the sulfur. You're going to be regulating the calcium, magnesium, the bicarb. All those are needed to be regulated.
Is that before or after they're like reabsorbed in like?
So this is the urine. It's out.
Really?
Yeah,
How
they
come it
just
still be
finish.
like yellow then? If it's 95% water, how can it still be really dark?
Because 5% is too much.
Oh, okay, okay.
5%. That 5% is a lot.
Because even though 5% is a little percent compared to
5%
it, it's
is a
still
lot.
A lot. Okay.
like if somebody were to say like only 2%
try to
of the
measure
population does this,
the
like,
Coke,
you
for
gotta think
example.
that's still a heck of a
The
lot.
percent of water in a Coke, like 99%.
Mm.
And all the sugar, everything else is going to be one less than 1%.
Mm.
Alright. And still dark. Normally, having high concentration of any of the components of the urine means I have a pathology most of the cases. So if I find blood cells out in the urine, this means I have a problem with my filtration membrane, or I have an injury in the urinary tract. If I found plasma proteins, this means that there is something wrong with my filtration. The plasma proteins are not supposed to move out in the urine. If I found glucose, lots of glucose in the urine, I'm not supposed to release this amount of glucose in the urine. So I have too much glucose in the blood that was filtered beyond the ability of the kidney tissues to reabsorb. For example, if I have too much calcium in the urine, I'm not expecting this amount of calcium to be released. So this means I have something wrong going on inside the body that causes the increase of the blood calcium level for this blood calcium to move later on into the urine. Alright, so you see on here, changes in the concentration of different solids, different components of the urine gives you an idea about what's going inside in the blood. It's like a mirror to what's going on in the blood. Moving on to the homeostatic imbalances, chronic renal disease is going to be diagnosed if a person has a GFR less than 60 milliliters per minute. Can you remind me what is the normal GFR?
Less than
120 to 125 milliliters per minute, right? So if you drop it by half,
What was that number?
this is chronic renal disease. All right? 60 milliliters per minute. Less than 60 milliliters, this is chronic renal disease.
Ooh, child.
If I have chronic renal disease, what's going to be my problem? My problem is that I'm not able to get rid of the nitrogenous waste, and those are acids.
Mm.
So if I kept accumulating acids in my blood, this would cause acidosis. Alright? So as we're going to see later on, this is a type of metabolic acidosis that will result from chronic renal disease. Alright, what are the leading causes here for chronic renal disease? It's going to be diabetes and hypertension. Diabetes and hypertension. Why diabetes will cause kidney problems? Because of the inflammation of the terminal vessels. If I am inflaming those vessels, how your body will respond to inflammation? How it heals itself? By fibrosis. Remember, what was the structure of my filtration membrane? What are the three layers of the filtration membrane? I have endothelial cells, then I have basal membrane, then I have photocytes, right? So if I am healing by fibrosis, you're adding collagen fibers in between.
Will this allow you to have normal filtration? What do you think?
No.
No. So inflammation of the vessels will be healed by fibrosis, and this fibrosis will be reducing your ability to filter. And when it drops to 60 or below, this means it's gonna be chronic renal disease. Renal failure is gonna be a diagnosis of GFR less than 50 milliliters per minute. 15 milliliters per minute or less, this would be the GFR that I will be considering a renal failure. At this point, this amount of filtration is not going to be able to get rid of the waste. All the waste will be building up in my blood, and pH imbalance will be taking place. That's why any person who's renal failure needs to be on dialysis. Because if we were not able to get him on dialysis, this person will not be able to maintain normal homeostatic activity. We're going to be putting him on dialysis until we find a suitable candidate for kidney transplant.
Last year I got sick. I had I got dehydrated, and basically I didn't go to the hospital, but I went into renal failure, and I went in. They didn't do a dialysis, so why wouldn't they have done a dialysis? But I was in renal failure, and spent a good 4 days in the hospital. So, but they didn't do a dialysis.
They didn't do dialysis.
No.
But you are kept in the ICU.
I was in ICU for about 4 days
So
at St.
they
Vincent's.
should be able to monitor.
Hmm?
So you, as far as you are in the ICU, you are monitored.
Yeah, I was on the
Everything is monitored.
Hmm.
So if you've got acids building up, they will be taking care of it.
Okay.
Of course, they are monitoring everything. As a dialysis, if I did allow you to move out of the hospital with failure,
No, okay, yeah.
right, I need to make sure that you've got enough time to build up more of the waste while you are out of the hospital. But if you are monitored every second in an ICU,
Oh, okay.
yes, I don't want to do this. I will be just regulating all the stuff.
Okay.
All right. This is mainly in acute. Here is more chronic. Acute renal failure. This is more intense and severe, and it takes short to treat.
So that's basically like very last option if they can't figure out that they can improve it.
It has been going on for years.
Okay.
For chronic renal failure, it has been going on for years, and this is going to be irreversible. Alright? It has been going on for years. This will be kind of inflammation.
Okay, you saying that it's irreversible. Well, my aunt, she's actually facing this, and they told her if she can get it back up to like 60 or 65, that she probably don't want to have to go on dialysis. But you're saying it's irreversible, so how can she get it back up? You understand what I'm saying?
Yeah, would she get a normal GFR at any point? Normal GFR?
She said she got it, and I think they said it was less than 60.
And she was diagnosed by renal failure?
They're talking about they haven't put her on dialysis yet, but that's what they told her she can't get back up to 65.
I need to check the reports, be able to even think about the condition.
Okay. But they told her she do have a chronic.
I need to look at the kidney functions, I need to figure out many stuff in order to give you my opinion. All right. Kelly, what might cause incontinence? Two major reasons for incontinence. Those would be like stress incontinence or overflow incontinence. We've seen overflow incontinence. If I'm holding, my external urethral sphincter will be fatigued. The pressure inside the urinary bladder will exceed the tone of the external urethral sphincter. This will cause and uncontrollable urine dribbling or voiding. This is in case of overfilling incontinence. Stress incontinence, if I did put more pressure on my filled urinary bladder. So like in case of cough, remember the guy, in order to get his blood back to the heart, what did he do? He did create a negative pressure within his chest. He did create a positive pressure because of the contraction of his muscles of the leg, right? Remember this old guy who lost consciousness in the restroom early in the morning? Yes?
Yes.
Yeah, so here is gonna be topic. So remember, why did he lose consciousness? Because he was increasing the intrathoracic pressure. He's pushing down, right? So here, why cupping will increase the pressure? Because cupping is simply like the Valsalva maneuver. You are blocking the airway, you are compressing your chest, and as you compress your chest while you're blocking the airway, you are increasing intrathoracic pressure, and as you increase intrathoracic pressure, you're going to be increasing the intra-abdominal and intra-pelvic pressure. So as if you're compressing the urinary bladder from above. So when I cough, laugh, what's going to happen? Increasing the pelvic pressure, increase of the stretch, where I have a stretched urinary bladder filled with urine, this will push urine out. Same concept with pregnant women. Okay, so at time of pregnancy, the uterus is compressing the urinary bladder. You see on here, the uterus is directly located behind the urinary bladder. So during the time of pregnancy, this uterus is going to be expanded. So the available space for the urinary bladder to accumulate urine is going to be much smaller. So that's why pregnant women will go more often to the restroom, because the urinary bladder is not expanding to its maximum. All right, it's compressed by the uterus. So I might lose control at some point during pregnancy, and I won't be able to regulate the urine out. So I might have uncontrollable voiding. Why? Because of the increase in the pressure. This is called, again, stress incontinence. Stress incontinence, this is different again from my.
So what about old people?
What about the? It's a weak muscle.
Yeah.
Weak muscle. Weak muscle. This is a short answer, but you cannot say just something general. You need to look at each person and what are the underlying reasons. But generally speaking, I have weak skeletal muscles also, and one of the skeletal muscles is going to be externally All right. So, renal calculi, triads. Triad in here. In case of stasis, if the urine flow is slowing down, what's going to happen? If the urine flow is slowing down, if I develop stasis of the urine flow, this will result in two things. First thing is going to be infection and kidney stones. Kidney stones will be blocking the urine flow. And if I block the urine flow, what's going to happen? Stasis. And once I get stasis, I will develop infection. Infection increases my risk of developing kidney stones, which will cause stasis. And stasis will result in
Infection.
developing of kidney stones, and kidney stones will put me at the risk of developing an infection. Infection will cause stasis that will result in kidney stones. So this is a triad. Anyone can cause the other two. If I have kidney stone, I have an increased risk of developing UTI due to the stasis. And if I have an infection, a UTI, this increases my chances of developing a kidney stone, which will result in stasis. If I have stasis, I'm not going to the restroom as frequent as I should be doing. I am holding the urine inside for a long time. So what's going to happen? You are reducing the flow, you have stasis, and this puts you at the risk of developing kidney stone and UTI. Alright, so again, triad in here that we need to focus on is going to be stasis, infection, and kidney stones. Having one will cause the other two. Alright? What might cause kidney stones? Accumulation of calcium, magnesium, and uric acid. Those are the three most common types of kidney stones. What's going to be the problem here with the kidney stones? I will be blocking the ureter, and this will cause hydronephrosis. What's the problem with hydronephrosis? Simply, it's going to cause renal failure if not detected early in the disease. So, this is with this cyst. So, if I've got a blockage here of the urine outlet, I do develop stone that did block. This will cause hydronephrosis. Hydro is water accumulation and nephrosis of the kidney. So hydronephrosis is simply I'm increasing all the conduction, the size of all the ducts of my kidney. The minor calyces, major calyces, and renal calyces all will increase in size. And as you increase the size of those ducts, what's going to happen? You're going to be compressing the tissue of the kidney, causing renal failure. Other reasons for an enlargement here, accumulation of fluids, it might be the cysts on here. So we have many different types of cysts, and each one is going to be determined according to the appearance of the cyst, according to the size of the kidney, and according to the contents of each of those cysts. Alright, so this to give you a general impression about how the differences will look like. So this is called the medullary cyst. This is the autosomal dominant polycystic kidney disease. This is a benign cyst, single cyst. We have different ways to diagnose here according to the kidney size, according to the cyst size, according to the cyst location in the kidney, and according to the state of the liver functionality. All those are going to need to be detected, and we're going to be most probably, before we perform any surgery, we need to perform a CT scan to see the location of the cyst in those kidneys. And according to the location and the size of the kidney, this gives you a good impression about what kind of cyst we're dealing with. Alright? Looking on here, this would be how the kidney will look like under the microscope. If you can remind me, what is the epithelial lining of my glomerulus? In order to allow filtration, do you need to have high resistance or low resistance?
Low.
Minimal resistance. So what kind of epithelium would be lining my glomerulus? Simple squamous epithelium. And simple squamous epithelium here, this is what we call my endothelium, because this is going to be blood vessels. What is the whitish part around the glomerulus? This is my Bowman's capsule. This is a cup-shaped tube here of my kidney. Cup-shaped tubes, this is my Bowman's capsule. Looking at the kidney tubules, how would I be able to differentiate between the proximal convoluted tubules and the distal convoluted tubules? You see on here, I have kidney tubules, and those kidney tubules are all gonna be lined with simple cuboidal epithelium. How do you think I will be able to tell which one is proximal, which one is distal from the appearance on here? You see on here, the ones with clear lumen. What do you think those will be? Distal. Why distal? I don't have much microvilli. Exactly. You see on here, compared to the proximal convoluted tubules, I have this fuzzy appearance. Why do I have this fuzzy appearance of the proximal convoluted tubules? Can you see the difference? How clear this one compared to this one has a fuzzy lumen? It's not clear inside. Why do I don't have a clear lumen in the distal convoluted tubules? Because in the proximal convoluted tubules, because I have dense microvilli. And remember, why did we have dense microvilli? Because 65% of the sodium and water is going to be reabsorbed. I am mainly concerned with reabsorption at this part of my kidney tubes. Moving on to the body fluids. Actually, half of the people did already left. Celebrated Valentine now. Alright. Valentine is celebrated by the kidneys, not the heart. Alright, so next time we're gonna start with our body. Alright, so I don't want to be good today. Alright? It will be another day. Alright, so for those who have completed their assignment, their lab work, please bring it for me. If you didn't have it, that's fine, you get it for me next time. Alright? On your way out, please print your name. Print your name.
Oh. Well, I now feel less lost. What you got your slandering?
Good
for whoever.
3 hours. So what else did you give your friend other than the donut? You did give him coffee. Coffee is also a diuretic. Alright? So caffeine is gonna be acting in a different way. It's gonna be preventing sodium reabsorption. If I didn't retake the sodium, if I didn't get the sodium back, would I be able to allow the water to follow the sodium that I did not take?
No.
Alright. So if you didn't reabsorb this water back, because you didn't move the sodium in the first place, so what's going to happen to the amount of water that will be released out in the urine?
It's gonna increase.
It's going to be increased. And if you increase the water released in the urine, this is what we call diuretic. So back to our short story. Osmotic, like glucose, sugar, alcohol, and caffeine. You're going to stop in the first gas station, right? Diuretics.
What did you say caffeine prevents sodium from doing?
It's going to be what?
What did you say that caffeine prevents sodium from doing?
Reabsorbed, from being reabsorbed. So you see on here, it's preventing the sodium reabsorption. It is sodium reabsorption.
So for people who drink coffee a lot for breakfast, is it best to eat a salty breakfast?
To
Eat a lot of sodium for breakfast if you drink coffee?
It's not recommended to take lots of caffeine and salty
Because there's
meals.
some people that feel like they can't live without coffee.
Yeah, but if you kept doing this for years and years, you might exceed the ability of the kidney to compensate, so that you're putting yourself at the risk of developing hypertension later on. Alright?
And then, I didn't catch that last one that you said. You said there's 3 pressures that affect the filtration was the hydrostatic, osmotic, and
Here,
Yeah.
Yeah.
so if I'm pushing out, this is hydrostatic. So you're pushing out from both sides. You're pushing out from the blood, and you're pushing out from your Bowman's capsules. Those are opposing each other. So this is called hydrostatic. But you are pulling back on both sides in case of diabetes. Why I didn't consider it normally with normal people, I don't consider the osmotic pressure in here. I don't consider it. Why? Because simply, most of it was going to be reabsorbed. All of it's going to be reabsorbed in the proximal convoluted tubes. All right. So here, what pulls normally back is the presence of lots of solids in your blood. This is called the colloid osmotic pressure of the glomerulus. So this is my glomerular colloid osmotic pressure. It pulls water back into your blood by a force of gravity. We don't have this force, osmotic pressure, within your capsule. We don't have capsular osmotic pressure unless we've got another problem here, it's diabetes. So we don't usually consider this as part of the filtration effective pressures, all right, because it's negligible. We're gonna only consider it, and it's gonna be effective in case of diabetes. Does this answer your question? All right, we can have a break for 10. We come back, discuss more about
Lost my balance.